particularly those with headaches. So case 2, so a 32-year-old male who's minding his own business when he was assaulted by these two guys. He complains of pain and vision loss in his left eye shortly after the assault. The physical exam doesn't reveal any pathology other than the visible trauma there, and nothing going on with the right eye. However, exam of the left eye is limited due to periorbital pain and swelling. So how can ultrasound help us in this patient? Ocular exams are often challenging in our trauma patients, again, due to swelling and pain. However, these patients are also going to be at increased risk for things like uncal herniation and intracranial hematoma, both of which may cause decreased consensual light reflexes. One of the reasons we check light reflexes in these patients. However, if you can't get that eye open, you can't check it directly, but this is where ultrasound is useful because you can check it with ultrasound. And as you might guess, we're going to talk about consensual pupillary reflex. So you're using your linear high-frequency probe. You can actually do the pupillary reflex in two views. There's the transverse view, where the patient is looking straight ahead, the probe is aimed posteriorly perpendicular to the eye, as with the rest of our ocular exams. Or you can do the coronal view, where the probe is going to be aimed slightly inferiorly at an angle, and the patient looks cephalad or down towards their feet. Either way, doesn't really matter. This is an example of the transverse. So at this point, you would be shining the light in the opposite eye, and then watching for that consensual light reflex. And here's the coronal view, which I think is particularly impressive because you can really see that iris responding to light. Very cool. I guarantee you if you show this to the staff in your emergency room, they're going to be impressed. We also use ultrasound to evaluate for vitreous hemorrhage. Again, we're going to be using our high-frequency probe, scan through the eye. Vitreous hemorrhage is going to appear as a hyperechoic material floating in that vitreous body. Remember, there's our vitreous body. That should be hypoechoic, should be nice and black. But if you have a vitreous hemorrhage, you're going to get some hyperechoic stuff floating around in there. We can also check for lens dislocation. Again, this is going to be useful in your trauma patients. This is oftentimes something we got to get ophthalmology involved with sooner rather than later. So again, everything's the same, scanning through. Lens should be located in the anterior chamber. So again, there's our lens, there's our iris. And if it's not there, then you can look around and you may find it just sitting in the back of the vitreous, such as this image demonstrates, or just floating around in the middle. And in case you didn't catch that, it's right there. This person also has a globe rupture and a number of other problems. So let's talk about case 3, the 52-year-old male presenting with 3 hours of atraumatic painless vision loss in his left eye. His symptoms started as some flashing lights in the periphery and progressed to a large visual field deficit in his inferior visual field. No other symptoms to speak of. Physical exam reveals an inferior visual field defect in his left eye. So how can ultrasound help us with this patient? Well, oftentimes when we think about our differential for his vision loss, our first branch point is going to be painful versus painless. I'm not going to go through every single painless vision loss diagnosis, but what's important for us here is that retinal detachment is one of the most emergent. That's one of the ones we need to know about because we need to call in ophthalmology because the person might potentially need to have their retina tacked back down. However, we're pretty limited due to our lack of dilation and other confounding factors. Again, fundoscopic exam is going to be challenging. And if you've ever actually seen or had an ophthalmology exam for retinal detachment, they do an extensive view of the retina with this little magnifying thing and all this craziness. It's just not something we're going to be capable of in the emergency room. But we are capable of bedside ultrasound. So as you might guess, we're going to talk about retinal detachment. Again, linear high-frequency probe. You're going to be scanning through the eye, and the retina is going to appear as this hyperechoic membrane. So again, remember our normal eyeball, retina should be tacked down, shouldn't be floating around. And again, remember here, we've got all our anatomy, that retina should be tacked down. This slide is important because I want to emphasize one point before we start looking at the retina images. This is the retina has two natural areas where it's attached to the eyeball itself. One is at the ora serrata, which is there, and then additionally at the optic nerve. This is important because, as you're going to see, it's potentially easy to confuse retinal detachment and vitreous hemorrhage because they're both going to be these sort of hyperechoic objects. So here you can see we've got this hyperechoic membrane sort of floating around in the back there. In case you can't see it, there's a little arrow for you. And again, here's another one. And you can see, so see how it's attached to the aspect of the eyeball. So again, if you see those attachment points, that's going to suggest retinal detachment as opposed to vitreous hemorrhage. And again, it's hyperechoic. Here's a nice little video. So you can see there that membrane is just kind of floated up, but again, is still attached at the two endpoints. And so that's going to help you differentiate between that vitreous hemorrhage. So there's a paper published in Academic Emergency Medicine back in 2010. So basically took 48 patients that had some acute visual changes, did some ultrasounds. 18 patients had retinal detachments and were all correctly identified. So they were true positives. Of the 30 patients without retinal detachment, 25 of them were correctly identified. However, 5 of the patients were misidentified as having a retinal detachment when they actually had a vitreous hemorrhage. So again, this is why I was emphasizing those points. If you think you have a retinal detachment, you want to look for those attached edges on the hyperechoic membrane. And then additionally, remember that ultrasound is going to be an adjunct to your HMP. So you still want to attempt a fundoscopic exam. And obviously if you see this on your fundoscopic exam, that's going to make you think vitreous hemorrhage, not retinal detachment. So you've got to take it all in context. But I still think that paper demonstrated, that the sensitivity is 100%. So if I can 100% say that someone doesn't have a retinal detachment, I think it's useful. Just make sure you keep those other things in mind if you actually are going to try and call it a retinal detachment, because we don't want to call ophthalmology up if we don't need to. So again, get out there, ultrasound your patients. If you have any questions or comments or suggestions, email me, text me. I will usually respond within probably about 24 hours. And here are some references if you want to go watch any extra videos or reading extra articles. Go to it, have fun,